So the disease of the mitral valve could be either a pure mitral stenosis, it's a resounding, or a pure MR, or a combination of mitral stenosis and mitral regurg. And this combination could be mild to severe MS with a combination of ranging from mild to severe MR. As has been told by Dr. Meenakshi, following an acute rheumatic fever, development of chronic rheumatic heart disease in the post-penicillin era ranges from 35% to 66%, and mitral regurgitation is the most common lesion following a bout of acute rheumatic fever. But the commonest cause of mitral stenosis, as high as 99%, is rheumatic. 25% of the chronic rheumatic heart disease have pure MS, and 40% of the chronic rheumatic heart disease have combination of mitral stenosis and mitral regurgitation. The female is to male ratio is 2:1. We have been taught about this. Mitral stenosis occurs because of fusion of the mitral apparatus. There could be 4 types of fusion. Either it is commissural, which is about 30%, it could be cuspal, caudal, or most often than not it is combined. There is no history of acute rheumatic fever in about 50 to 60% patients of mitral stenosis. It is because of the scarring, inflammation and neovascularization of the valve with fusion, thickening and calcification that lead to a funnel type mitral valve apparatus, which looks like the mitral valve opening looks like a mouth of a catfish, which we call in echocardiography as a fish mouth appearance. In Western countries, severe mitral stenosis is seen usually in 5th and 6th decade because following a bout of acute rheumatic fever, there are about 2 to 3 decades of silent period before it is manifested. However, in our country, Sub-Saharan Africa and Southeast Asian region, severe mitral stenosis seen a decade after acute rheumatic fever and sometimes even within 5 years after acute rheumatic fever. The commonest is the 2nd and 3rd decade, but even we can see within 6 to 12 years. The commonest stage of presentation of mitral stenosis is 2nd and 3rd decade. There is a word which has been coined by Professor Tandon, is called juvenile mitral stenosis. When we see a mitral stenosis, they are less than 20 years of age, they are very aggressive and they have a disproportionate severe pulmonary hypertension. This is the classification which we were following till recently, the severity of mitral stenosis. This was ACC-AHA 2006 guideline wherein they have divided to mild, moderate and severe. Mild we call when the mitral valve area is more than 1.5 centimeter square, the mean gradient is less than 5 and pulmonary artery systolic pressure is less than 30. We call it moderate mitral stenosis when the mitral valve area is 1 to 1.5 centimeter square, mean gradient is 5 to 10 and pulmonary artery systolic pressure is 30 to 50 millimeter of mercury. Severe MS again MVA less than 1, mean gradient more than 10, PASP more than 50. However, recently there is a change in the 2020 guideline. There is a change in the severity of mitral stenosis, and the ACC-AHA have staged the mitral stenosis into 4 stages, namely stage A, B, C and D. Where they have stage A is at risk of mitral stenosis. The valve anatomy is a mild valve doming during diastole. The hemodynamics is normal transmitral flow in velocity, no gradient. Consequence is none, symptoms are none. Stage B is progressive mitral stenosis where the rheumatic valve changes with commissural fusion and diastolic doming of the mitral valve is seen and the planimetered mitral valve area is more than 1.5 centimeter square. The normal the valve hemodynamics is increased transmitral flow velocity, mitral valve area is more than 1.5 centimeter square, diastolic pressure uptime is less than 150 milliseconds, the hemodynamics mild to moderate left atrial enlargement, normal pulmonary artery pressure, symptoms are none. C is asymptomatic severe MS where they have seen rheumatic valve changes with commissural fusion and diastolic doming of the mitral valve plates. And planimetered mitral valve area is less than 1.5 centimeters. Meaning thereby now they call severe MS if the planimeter area of mitral valve is less than equal to 1.5 centimeter square. The mitral valve area again by valve hemodynamics is less than 1.5 centimeter square if you do a pressure uptime. The diastolic pressure uptime is more than 150 milliseconds. The hemodynamic consequence will be a severe LA enlargement and the PA systolic pressure is more than 150 and the symptoms may be none. So this is a group of severe asymptomatic mitral stenosis where you can pick up whether when they land up with a complication like a CVA or a acute pulmonary edema. But otherwise, if you ask them a history, they say, no, I was absolutely symptomatic 7 days ago. So group D is symptomatic severe MS where everything is same. Again, all the parameters will be same, severe but then the symptoms are decreased exercise tolerance and exertional dyspnea. One thing they have taken very categorical here, the transmitral mean pressure gradient should be obtained to further determine the hemodynamic effect of the MS and is usually more than 5 to 10 within 5 to 10 millimeter of mercury in severe MS. However, because of the variability of the mean pressure gradient with heart rate and forward flow, it has not been included in the criteria for severity. So this our DM students should know. Then coming to the complications, everybody, all of us know from our MBBS stage, the complications are acute pulmonary edema. Acute pulmonary edema usually occurs early in the natural history of mitral stenosis. Then hemoptysis, Dr. Paul Wood has described 6 causes of hemoptysis in mitral stenosis, but the commonest and most severe form is called pulmonary apoplexy, which is because of the rupture of bronchial veins, which can lead to a massive hemoptysis. Then, of course, atrial fibrillation with the systemic embolism like CV and peripheral embolism is a very common complications. Then, if untreated, they develop severe PH. And in India, we see every day in our clinical practice patient, when they come to us, they have severe PH and TR and symptoms of right ventricular failure. But in the pre-surgical era, death due to heart failure was 62%, thromboembolic 22%, and infection 8%. But this has been changed with the use of antibiotics, over-the-counter use of antibiotics and analgesics. But untreated symptomatic mitral stenosis, if somebody asks for the natural history, the 10-year survival is 0 to 15%. The diagnosis is clinical. Dr. Meenakshi has told nobody is auscultating now, but people like us, we used to auscultate. See, and in the DM, we will ask also a patient, if there is a mitral stenosis, we will ask, how do you decide about the severity? The severity of the mitral stenosis is decided upon 2 direct signs and 1 indirect sign. The direct signs are the gap between the A2 and OS and the length of the murmur. And the indirect signs, if you have evidence of severe PH, then you say it's a severe mitral stenosis. And then mild and moderate is very easy to find out. ECG sometimes may be a normal ECG except a left atrial enlargement or little rightward shift of the axis. But consequent to the development of severe PH and right ventricular failure, you get right axis deviation, biatrial enlargement and right ventricular hypertrophy, and atrial fibrillation occurs as high as 50 to 60% of the patients of mitral stenosis. X-ray chest, of course, we ask the X-ray chest classical finding, which is seen as a mitralization of the left border because of the engorgement of the left atrial appendage, the prominence of the main pulmonary artery. We see evidence of PVH and PH. And echocardiography remains the gold standard, as has been told by Madam, and that confirms the diagnosis. You can decide about the severity, you can decide about the scores, there are several scores, and then whether this patient is a suitable candidate for a percutaneous treatment or he needs surgery, depending on the scores, the mobility, the calcification, the subalveolar fusion, and so on and so forth. And you can also rule out associated lesions like mitral regurgitation associated outflow for disease. And a cardiac cath is being rarely done unless you are doing a PTMC. The treatment, I am not going to elaborate on this. The medical treatment, beta blockers, digoxin, diuretics, oral anticoagulants. If there is a atrial fibrillation, it's mandatory. And secondary prevention, Madam has already told about it. One word about digoxin. Digoxin has no role in a patient of severe mitral stenosis in sinus rhythm. If there is atrial fibrillation and you have given beta blocker optimum dose, still the heart rate is not controlled, then you have to add digoxin. Then the second treatment, of course, as far as we are concerned, PTMC, if this is a suitable candidate for PTMC, you have to look holistically to the entire mitral valve, not you just don't go by the score. See, if there is a calcification in the body of the mitral valve and the commissures are free, still he is a candidate for PTMC. And if there is a mild to moderate MR and the MR jet is central, it's not eccentric, If it is a central jet, you do a PTMC, successful PTMC, the MR will disappear. At least it will not increase. But if it is an eccentric MR jet, don't do a PTMC. Then the surgical, the closed mitral commissurotomy was a wonderful surgery maybe 4 or 5 decades ago. People who have undergone, sir, I am following up patients who have undergone closed mitral commissurotomy and the mitral valve area is still 2 centimeters square, no MR for 2 decades, 3 decades. It's a wonderful surgery, but the new generation cardiac surgeons, they don't know how to do it. And the last but not least is mitral valve replacement or repair, which I think the subsequent speakers will be talking about it. Then coming to the mitral regurgitation, I will be very brief. The pathophysiology is shortening, rigidity, deformity and retraction of the leaflets, shortening, fusion of the chorditendinae and papillary muscles lead to, ultimately that all lead to a poor coaptation of the mitral valve. And again, the 2020 ACCHA guideline again staged the chronic mitral regurgitation to stage A, B, C and D, but they have mixed up everything, mitral valve prolapse and rheumatic heart disease. So I am not going to detail about this. We know how to assess the severity of the MR, mild, moderate and severe. There are clinically by ECG, echo and echocardiography, and echocardiography remains the gold standard. Here they have hemodynamic consequences, same thing they have both, but they have mixed up everything with rheumatic, infective endocarditis and mitral valve prolapse, but I am not going to speak details about it. Then the treatment of mitral regurgitation is again medical and surgical. If it's a mild and moderate MR, mostly asymptomatic, you just give them chemoprophylaxis against rheumatic fever, that's it. If it is a severe MR, it could be asymptomatic severe MR or a symptomatic severe MR. Then asymptomatic severe MR, when you start treatment, the surgical treatment, again there are guidelines and the most important is echo. And if you take the two commonest echocardiographic criteria, if the ejection fraction is less than 60% and the left ventricular end diastolic dimension in systole is more than 40, even if it is a severe asymptomatic MR, he is a candidate for surgery. Because once this LV dysfunction sets in, the surgical mortality and morbidity remains very high. So that is, and the role of medical treatment is minimal. People started giving ACE inhibitors, ARB, but there are no strong evidence to suggest that it can delay or prevent the progression of the MR. We are being taught in our MBBS stage, MR begets MR, sir. Any senior person here will say, MR begets MR. Once there is a MR, it goes on increasing and ultimately you go out to have a severe MR. Then coming to this combined MS-MR, this is the classical, because in a DM examination, no straightforward MS or a straightforward MR is given. We give a combination of mitral stenosis, mitral regurgitation with a aortic valve disease. This is the commonest as a long case or a short case as MS and MR. So there can be so many varieties. It could be a mild MS with mild MR, where they are asymptomatic. You just put your stethoscope and very careful clinical examination by an experienced cardiologist will be able to pick up this mild MS and mild MR, or otherwise you will miss it. Then there is a mild MS with moderate MR. Here we will have more features of MR. You can suspect a mild MS if at all you get a loud first heart sound. Then mild MS with severe MR. Here all the features of MR will be there, including, because you cannot make out, there may be, in the severe MR there can be MDM because of the flow MDM. And if you are getting a S3, you rule out mitral stenosis. So this is also again very difficult because most of the signs, clinical signs will be severe MR. Then moderate MS with moderate MR, again, you have to clinically judge, and it is difficult which one is moderate, which one is mild, but one senior clinical clinician can be able to make it out. Then severe MS with mild MR will have all the signs of a severe MS. But if you carefully examine, there will be a hollow systolic murmur in the mitral area localized. But sometimes in a severe MS with severe PH and TR, the TR murmur can be heard over the apex. So you can say that it is a MR, but again, it needs a very careful clinical examination. Because the treatment is determined on the severity of the MS, mild MR doesn't interfere in the treatment of mitral stenosis. So severe MS with moderate MR again you have to, all signs of severe MS, but MR murmur will be very clear. There is no doubt, there will be no doubt in picking up the MR murmur. Then severe MS with severe MR. This is a rare entity. Clinically, one should not tell. I'll ask if there is any DM students or DNB students, don't tell severe MS and severe MR as a clinical diagnosis. This is an echocardiographic diagnosis because they say if there is a severe MS, there cannot be severe MR. It has been, this is a common teaching. However, there can be fixed REPs and it could be lead to a, we have seen in our clinical practice by echocardiography, there can be a group of patients where there is a severe MS with severe MR. And if there one thing I will tell you here, if you are getting an opening snap, there cannot be a severe MR. If you are getting a third heart sound, there cannot be a severe MS. Then again the cardiomegaly, left ventricular type of apex favors diagnosis of severe MR. If you get evidence of severe pulmonary hypertension, it favors the diagnosis of severe MS. So likely clinically you have to have a clinical judgment, patient's history, then you go for the ECG, you go for the X-ray, and finally you do the echocardiography, and which will clinch the diagnosis. So clinical diagnosis of each lesion severity usually is difficult. Certain findings give clue to the severity of MS and MR, as I have already told. ECG and X-ray can help to some extent. However, echocardiography remains the gold standard investigation to confirm the severity of each lesion. So the treatment of this severe MS and MR combined lesion depends on the dominance of each lesion. Medical therapy guided by the severity of the lesion we have to do. Percutaneous intervention in selected cases, as I told, that severe MS with mild MR to moderate MR, central jet, you can still go ahead and do a PTMC. The MR will either come down or disappear. Surgical treatment is indicated in the majority of these such patients. So thank you for your patient hearing.